Top Med Talk.
Welcome to Top Med Talk. This is part 2 of a 3-part piece. Part 1 presents a short introduction to the subject of volume and cancer outcomes. It's presented by Shaman Jhanj, Head of Anaesthesia and Intensive Care Research at the Royal Marsden Hospital. He's now joined by the rest of the panel in this part 2. We have Blanche Symons, patient representative, an ex-patient of University Collage London Hospital. Dan Martin, consultant in anaesthesia and intensive care medicine, working on the intensive care unit at Derriford Hospital, and is co-chaired by Denny Levett, professor in perioperative medicine and critical care at the University of Southampton, and Tim Wigmore, consultant anaesthetist intensivist at the Royal Marsden Hospital.
So I think there was a fantastic review, both of the paper itself and the broader topic about whether we genuinely think that the volume that the anaesthetist or anesthesiologist undertakes has a genuine impact on outcome, and the wider implications of that, both for individual patients and for institutions, about if that were to be the case, how are we going to arrange both for the individual institution and for regional and national services. So kick off the discussion and then obviously invite questions from the broader audience, because I suspect that everybody is operating in different circumstances where this way may or may not be broadly applicable. Following your suggestions, Sham, starting off initially about the broader application of the findings of that study to a healthcare setting that it wasn't actually designed to assess. So do we think that a similar pattern is likely to exist within the UK? Dan, perhaps, yes.
I thought it was a fascinating paper, and having done a bit of reading before this panel, I've not actually come across this paper, and I think one of the questions I was going to raise is this is a very surgery, so it's very surgeon-focused, but I thought this was a fascinating look at anesthesiologists' impact on this area. And really, it's very hard to understand how this would be implicated. I worked for many years here in London, where there's 30 or so hospitals within the M25. So patient choice is relatively easy. You could choose between UCL or the Marsden or other great institutions. Those of you not familiar with Devon and Cornwall, our hospital lies right on the border between Devon and Cornwall. And we have a catchment area which includes the entirety of both counties. So a patient in Penzance, for example, would be a long train journey or a 2-hour drive up to Derriford, or if Derriford didn't count as a high volume centre for a particular operation, they would have to go to Bristol, which would be 4 hours plus away. So I think that there are real geographic issues to think about here. And I think Blanche will give us a great, hopefully, impression of what patients are and are not prepared to do. And I think these sort of internal reorganizations of departments based on data such as these will be a huge challenge in an already very challenging landscape that we have post-pandemic, where these vast waiting lists that we have to catch up on.
One comeback would be that, do you not think that already, if you look at the way that NICE and peer review is going, that there is already a focus on getting specific institutions to deal with specific areas of medicine? So you might have your stroke centre, you might have your cardiac centre, and you might have your high volume cancer centre. And, there are already specific volumes put on centres, for example, with hepatobiliary cancer, about the volumes that you need to undertake to be able to keep your institution as a referral centre.
I think so. And again, I think in larger urban areas like London, that's already happening with specialties moving out of one hospital into another to build up skills. But in an area where you are the only hospital, you are then expected to be the super specialist centre for absolutely everything. And I think that puts a great deal of pressure on a single institution to deliver a very high quality in every single specialty, because there's no alternative. So I think in some areas this may work, and large urban areas would be a great testing ground for these. But a great deal of thought would then have to put into moving this out to more peripheral areas of a country like England.
I think, just sorry to interrupt, but on that point, I think what's interesting is, because I agree that actually doing this is very hard, there's probably a ceiling effect, because actually if you look at all the data, the numbers are actually quite small. Yeah, so when we talk about high volume, when we're talking anesthesiologists, 6. When we're talking about the surgeons, it was sort of the leapfrog, say 7 procedures. So I think whilst there are absolutely guidelines around HPB, around upper GI, I wonder if they're slightly arbitrary, that actually one could have more hospitals with a medium number of cases ongoing, which would actually produce as good outcomes and would be, in practical terms, a more likely way that you can deliver services.
The number 6 was quite striking, wasn't it? Sometimes when you read a paper, you go, what, really? is that the number? 6? That's 1 every 2 months. So I was actually really struck by that. It definitely triggered my "is this likely" barometer.
Yeah.
Blanche, we had an NCPOD which publishes a whole bunch of reports on how we should be conducting sort of broader surgery and other things. They came out with a study in 2011 called Knowing the Risk, right? And they said that patients should be informed about the risk of high surgery. So do you think that an association with high volume surgery or high volume anesthesiologist or anaesthetist, should we be telling patients about that if it exists?
Yes.
Yeah. And so I think that's really fascinating because I don't think we do. I looked around for data about to what extent are patients aware of this. And all I could find was this pretty small study. Came out, I think, in 2016, 17. It was 76 patients coming out of Wisconsin or something, asking patients specifically what they knew about their surgery and then particularly around the volume impacts and then what would they do in response to that knowledge. And, it said, as Sham stated, around 40% of the patients had an awareness of the volume association. And actually the impact of that on their behavior, if we believe that very small study, was pretty minimal. From my point of view, I think if I was aware of a volume relationship that made a difference of a risk of 1.5, I would be really, a hazard ratio of 1.5, an odds ratio of 1.5, I would be really strongly going towards that area where they were undertaking that surgery. I mean, what's your take on it?
Well, with any surgery, you sort of say, is this your first time? I mean, I would definitely want to go to a place and a surgeon that did it all the time. I wouldn't want to be the newbie.
No.
Thank you, Blanche.
Yeah, we've got a few questions coming through Slido. In my context, high-volume anaesthetists tend to do regular lists with high-volume surgeons. So do we really believe that these two factors can be separated in these studies?
Within the multivariable logistic regression, they did try and correct for surgeon. Obviously, in any retrospective review, that's difficult. Why I thought that this e-value, this statistical modelling they used to try and look for sort of unaccounted confounding was really interesting, which is why I mentioned it. I'm not a stats ball. But, I thought that was quite an interesting look at it. But I think while they tried to correct for it, that may be relevant. But this analysis did try and separate that out. So I think it may be different.
And I think the other really interesting paper you presented was the meta-analysis, which was looking at the relationship between high-volume institutions and high-volume individuals. So if you looked on a sort of what was doing best, it was high-volume institution. Then it was sort of high-volume institution, it was high-volume surgeon, low-volume institution. Then it was low-volume surgeon, high-volume institution, then low and low at the end. So what that's telling us is that the team effect actually is really significant. If you work, even if you yourself don't do it that often, if the team does it, it boosts your chances of having a better outcome. I think that whole association between people that work together all the time and getting to know each other, they understand the niceties of the operation, I think it's a massive deal.
Dan, I think there's something to add.
I think it's very interesting looking at the story from the beginning to where we are now with the volume and outcomes. I got this feeling, Hugh reminded me of it yesterday during his talk, that it felt a little bit like the situation that we have frequently found ourselves in intensive care, where very early studies show great promise. And then when more and more complex studies are put into place and greater statistical models, everything becomes a bit more clouded. And I think one of the things that Sham mentioned, which I think is important to think about, is where the volume is just a surrogate for something else. And I think you mentioning this teamwork here is good. And what I didn't see very much of in the literature is much talk about standardized mortality ratio. So as someone who does a lot of intensive care, this is something we look at all the time to compare one unit to another unit. It seems slightly unusual that the literature had moved to a volume-focused indicator rather than looking at standardized mortality ratio. And when we're constantly looking at countrywide ICU data, it's quite frequent to have a funnel plot where you'll put a standardized mortality ratio, and on the x-axis you'll have volume in terms of how many patients you admit. And then you can clearly see who is an outlier, because I'm sure there must be high-volume centers that are outliers. And I don't know if either of you know much about why the shift has been towards volume and not towards a more measurable outcome like standardized mortality.
I mean, presume it's probably that the risk prediction models in ITU are much more robust.
Yeah, that's true.
So, we've had patchy scoring or whichever we want to use now, the Ignite scoring system, whereas I think my feeling would be for cancer surgery, those kind of scoring systems are less robust, and so therefore standardising the mortality would be so confounded again, because a simple right hemicolectomy might be performed in one hospital, whereas the more complex one, which involves a pelvic sidewall, might be somewhere else. We haven't got those scoring systems. I mean, I know one of my colleagues at the Marsden tried to develop some of this, where he tried to look at some of the predictors before surgery, but it becomes very complex in terms of adding in the neoadjuvant chemotherapy, the radiology, and actually the other thing is it's such a moving field with therapies changing so quickly that actually to develop that kind of scoring model is very hard, I think, is my view anyway. And therefore, to develop these standardised models would be difficult. That's even reasonable.
And that particular risk scoring model, it was a fantastic effort. But again, it was institution specific, because the variables that were feeding that into that were institution specific. So again, there'll be things that are, it's the confounding issue again.
And another good question here are really about the practicalities of centralisation, which is how do we reconcile the need to remain generalists out of hours with the improved quality of care by subspecialisation? And we find this with surgeons now as well. They focus on doing one operation at high volume, and then out of hours they're faced with completely different challenges. And how do we maintain that skill set?
I mean, I think that is the difficulty. I can say in the institution we work in, because we're very small, to be honest, we don't look at on-call raters. We just phone the person who's done the operation and they come and sort out any problems. And an on-call rater doesn't exist as such. We just phone whoever it is. Now, that isn't scalable. So you're right. I think it is a major issue. And as I tried to say, even if we're talking about perioperative physicians, if you've got 6 esophagectomy anaesthetists, the highest risk case is the emergency. So unless they then develop an on-call system where there's just the 1 in 6 for them, it doesn't quite work. So I agree. I think in practical terms, it's a very difficult thing to do. So one could suggest, for example, therefore, that this generalization is more important. And if there is a ceiling effect, then actually making sure that everyone does 6, because that's actually pretty easy, because it's only 1 every 2 months of these high-risk procedures, then you can have a bigger pool. And so, I mean, I don't think we're ever going to get the data that suggests where that ceiling effect is. But I think within departments, you'd have to look at the numbers and be pragmatic and work out how.
So, Sham, do you think
that.
what you're essentially arguing for is non-specialisation? So what you're arguing for is a rotation of people within departments so that they get to do 6 of everything a year.
I'm not arguing for it. I can see the practicalities within, the hospitals, within a big healthcare system. It's very difficult for people to actually deliver that. I think, the data suggests an improved outcome, and I think I agree with Blanche. I think if I was a patient, I'd want to know that, and I'd want someone who's doing that regularly. It's just whether within our systems we can deliver that. And if we can't, then we need to come up with a pragmatic view on that. And when the data for numbers is actually not that high a number, maybe that's a solution.
Blanche, can I just ask you a question about to what degree you think that we've been successful as a profession in rendering our outcomes transparent so that you've got something to make a decision about? So when you choose to come somewhere, are you genuinely choosing, or are you essentially just, particularly in the UK, faced with a referral from your GP that says, right, you're going there?
Well, I'm lucky in the sense that I know Dan and Mike and Denny quite well. So
That's cheating.
I have an inside track. And I was lucky with my treatment. And I ended up at a Center for Excellence at UCL. And I'm also an investigator. So I look for the information and I ask. A lot of people, I think, when they're given a diagnosis, are in shock for a while. And then sometimes they don't want to know. And some people, they just go by what their GP suggests. They just go down a certain path. But I question and I want to know.
When you question, did you get the information that was useful to make the decision?
Yes.
That's good.
Well, I got that the department I was going to was the Center for Excellence in the UK. So that I felt safest there.
Yeah.
But you would hope that there was enough transparency of data so you ended up in a centre of excellence, but actually, ultimately that's what we're all aspiring to be. We're all aspiring to be UCL. It's just about how we, obviously, how we reveal that information. So how do we put that out there so that people can say, I'm going to a centre? Anybody can put that on their door. We all say we're centres of excellence in reality. But to what degree is that actually being presented to anyone to make a choice. I guess that's what I'm trying to get at. How transparent really are we?
It's very difficult. And also you rely a lot on your GP and then the next referral.
Do you think, Blanche, a league table of outcomes or volume would be useful for the public?
Yes.
Yeah.
Yeah.
And interestingly, Blanche, so I mean, you were lucky because you live in London and
Yes.
UCL wasn't too far away. So if you'd found that the best volume and outcome was in Plymouth, for example, but it was only maybe 1 or 2% better than UCL or a centre in London, would you have been prepared to travel to Plymouth for your treatment?
If it was just slightly better, probably not. But I know, having lived in the States for a long time, I know, and having had family members with cancer, they've traveled, for instance, from Memphis to Houston to MD Anderson because it was a center for excellence for that particular. So they go for 2 months and you rent. Whereas, yeah, I think if it was quite a bit, if it was much better, I would certainly travel.
You would have travelled. And there's an interesting comment on Slido here, which I think is probably from our Australasian colleagues. And they said, the perception of distance is clearly cultural, but Australia, a 20-hour drive, it's not very far. Whereas we seem to think that 2 hours is a very long way in the UK. So I think that's an important point.
Can I add a couple more points on that? I mean, I think Dan's question about the outcome data is really interesting, but what outcome data would patients want to know? Because, a lot of these papers, they talk about mortality. I mean, we all know that isn't necessarily the most patient-centered outcomes. Actually, it becomes very difficult to know what outcomes we'd want to be telling patients about. And then the second thing is, and again, I think this is specifically around the NHS in the UK, whilst you might look at that league table living in London and realise that you're better off going to Derriford, the likelihood is that within the funding system we have in the NHS, you wouldn't be allowed to go to Derriford. So actually, even if we did publish this data, we haven't actually got a financial model within the NHS where patients can decide where they go. Because, again, if Derriford happened to be the best at what, they couldn't look after everyone in the UK. So it's interesting that we haven't got the data for the patients, but even if we did, we haven't got the system to allow them to make that choice because it's just not, the funding model doesn't work in that way.
Just back on Slido, we have a couple of overlapping comments about other specialties where we have either adopted a hub and spoke model like vascular surgery, saying, can we learn from that because aneurysm surgery has been increasingly centralised? And then the counter to that, which is the paediatric surgery issue, which means that essentially now no paediatric surgery happens in under twos outside of the specialist centre, but then still as at DGH, you have to do the emergency care of really small, sick children very intermittently, which is very stressful. What are your thoughts about balancing those things?
One thing I would say about cancer surgery, look, all cancer surgery is obviously not the same, but a third of all operations are cancer surgery. So the idea of specialist centres within the UK mopping up every single cancer procedure is, to me, a non-starter. So, it's all very well talking about specialisation, but actually I think what we've got to talk about is degrees of specialisation, because the reality is, as I say, it's a third of all operations.
And maybe, as Sham said earlier, maybe rather than thinking about moving patients to the higher volume centres, it's just avoiding being a really low volume centre. Because to get everybody above the 6 may be easier than moving people around the country and maybe preferential to patients. So making sure nobody's at the very, very low volume. Because 6 cases a year does really seem very little.
Seems very little.
I wouldn't mind that job plan.
I wanted to talk a little bit about MDTs, actually.
Yeah, excellent.
Just about, the importance of the MDT approach to selection of patients and to their initial treatment. And you raised that as a question. I had a little look into this. Now, you may be aware that we published something in 2017 about the effect of the MDT on patient outcomes. I was able to find one comparative study back from 2014, again from the US, looking at upper GI cancers, which demonstrated supposedly a hazard ratio of 1.4 for patients that weren't reviewed within an MDT. I'm really interested to talk about the extent to which anaesthetists and intensivists are involved in the MDT to try and get patients prepared in the best possible manner for their surgery, and what the wider experiences of people, to the extent to which they're drawn into the MDT prior to patients undergoing what, in some cases, really high risk undertaking. If anybody would like to comment, yes.
Helen Anderson from Derriford in Plymouth. We actually have a series of MDTs within the hospital that the anaesthetists attend. So I'm part of the HPB MDT. And we recently published some data that showed when we'd combined our pre-op service, increased the number of CPET tests we were doing, used our shared decision-making discussions. We now have combined clinics so that we will see the patients and test them in the morning, and then the surgeons will see them with those answers in the afternoon. And we've shown that we've actually not increased our HDU usage, but actually massively reduced the amount of patient returns to critical care. So I think it is entirely possible. And it's been really invaluable because we have a much better relationship with our surgeons. We now get many of the other specialties sending us people that they are really not keen on operating on, but are valuing our opinion and supporting them and the families and the patients themselves to get the right information to make the right decision.
Do you mind if I just ask as a backup to that, the allocation of time into job plans so that you're actually able to attend the MDT? Did you find that the support was there from the institution?
Yes.
And I think that makes a huge difference. I think it's very hard for anaesthetists and intensivists otherwise to attend because their job plans simply don't facilitate it.
I mean, my experience as well is it's slightly there is an issue, certainly in our institutions, with the function of some of the MDTs. And I've been to them for various reasons, not as part of my job plan, but I honestly think for some of them, the lung MDT goes on for the whole day, practically. And many of the decisions really they take 20 seconds. And I do wonder what the benefit of it is, because it's a very clear-cut, surgically resectable young patient, but it still has to be reviewed. And so unless somebody is prepared to put the work in ahead of time to work out which of the cases that require our input, it certainly wouldn't be worth my while to spend the whole day there. And so then you really need buy-in from the surgeons and from the teams. And one of the other things, certainly for the tertiary patients, is that we found that nobody actually knows anything much about the patient. There's one word, one line in the referral letter, this fit, retired 70-year-old, I'm always, engineer or whatever, always a bit worried by that. And so that makes it really difficult to contribute. And so I think it's fantastic to hear that happening where you are, Helen, but I think that the whole process of what we're actually trying to achieve in that MDT is, should we be reviewing every case, or should we be reviewing the tricky cases?
A focus series of cases.
Or putting the query cases at the beginning and then us inputting where our input's more valuable.
Which is what we tried to do at the MDT, actually, is to have essentially a series of potentially high-risk individuals being assessed as part of an MDT.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.